Good morning, class of 2013. That fiddling with the light was not meant to have you trip down the stairs, but to announce that we're beginning on time. And as medical students, you should all know, or many medical students, you should all know that there are such things as midterms. And today we have one. I know well, we're just assuming that you're all prepared, but I sort of know how you feel. So because midterms can be very intimidating, we're going to make this a little bit fun, and we're going to imitate our favorite show, Wait, Wait, Don't Tell Me. Anybody know Wait, Wait, Don't Tell Me? Okay, so we're going to replicate the famous Limerick Challenge. The goal of the Limerick Challenge, of course, is to fill in the blank when you come to the end of the limerick. And we'll everybody can chime in. We won't single out any student, but we will take the quality of your knowledge as a function of how many people chime in. So we need a lot of voices to sort of verify that you know things. I want to disavow at the beginning any signs of bias or political messages. I just try to get the rhyme. So here we go. Are you ready? Class, okay. That all meds make us better's a lie. From some drugs we might sicken and die. Pay attention to PIMS, remember what they are, or sing funeral hymns. You can help your health care if you... Oh gosh, you're so smart. Okay. Lecture number 2. You ready? Okay. If your nose runs, it may be because its permucous glands suffer from flaws. In cold weather, your nose uncontrollably flows, but gets better as soon as it flows. Man. My wife last night was scratching her head and saying, "Just pour me another glass of wine." Okay, here we go. The Affordable Care Act is named to imply healthcare costs have been tamed. But we know for a fact that this Health Reform Act, from conception to passage, got As I said, there was no political message intended. I just get desperate to make a rhyme. Okay, here we go. The dementia we know as Alzheimer does afflict, as a rule, the old timer. Exercising the brain extends memory lane. So write poetry, be a good You guys really absorb your facts. I am impressed. By the way, you all will have to get my voice on your answering machine or voicemail. And if you really want it, we'll send you to a psychiatrist. And we have a bonus Limerick Challenge because you are so talented. NPR's fine new quiz called Wait, Wait. Will news junkies with laughs satiate? Unless listeners give, programs like it won't live. Mini med school will have the same. Right. All right, there we are. And now I'm going to see if I can hook up our first presenters. Actually, you need to plug in. So we're going to unplug this computer and plug in Dr. Rogers' computer. So there'll be a moment here as we hopefully not lose our cords. Now, will this change our audio-visual? Because we're not going to have a, well, we'll see. Okay. Things are, okay. So, I'm just going to introduce Dr. Rogers while he sets up his computer. Dr. Jason Rogers is Associate Clinical Professor of Medicine and Director of Interventional Cardiology and the Cardiovascular Research Unit at UC Davis. His prowess with a cardiac catheter has propelled him into the forefront of minimally invasive cardiovascular medicine, cardiovascular procedures that are revolutionizing who can be treated and what can be treated without exposing the patient to potentially dangerous open heart surgery. You'll learn about some of that today. Dr. Rogers is author or co-author on numerous publications. He's also working on the development, interestingly, of a procedure for interventional vascular treatment of erectile dysfunction. It's what his bio says. And Dr. Rogers is hard to keep up with because he's often out racing one of his racing bicycles, which he's a fan of, and he's a devoted dad. And we are delighted to have him today as our presenter. Dr. Rogers.
Well, thank you so much for that kind introduction, Cal. And I must say that medical school has become much more enjoyable than I recall it being. So I think I could do it again if it were like this. So a couple questions. First off, the most common question I'm asked when I first see a patient after the usual formalities is, "How old are you?" So yeah, just so we're clear, I'm 43 years old. So there you go. And then the second most question is, "Are you a doctor?" "When am I going to see the doctor?" So that's also my second disclosure. I am in fact a physician. So today, what I wanted to do was, talk a little bit about some of the new, I think, and exciting therapies that we have for cardiac patients. Now, heart disease is prevalent. It is, the #1 reason for mortality in the developed countries, and so it remains an important part of any healthcare system and relationship. Now, heart disease has many facets. We're sort of soup to nuts. There's primary prevention. There's eating well, exercising, and trying to prevent a problem, which arguably is one of the most important aspects of what we do. But then once you do, if you do develop an issue, then there are different therapies. And while many therapies have traditionally been the domain of the surgeon, there are some changing relationships over time, and my dream is that we will eventually not require large invasive procedures. So the theme of my talk really is minimally invasive, and this is not no invasive. This is not Star Trek where we're simply waving a wand over someone, but the idea is to minimize the invasiveness of a procedure and allow patients to recover and return to their lives without delay. So I have a couple things I'm going to cover here over the course of the 45 minutes. And of course, this is going to be more of a 30,000-foot fly overview, and hopefully give you a flavor for some of the technologies that are currently available and that are under development. Now, this is a picture of a human heart, and you can see that this is about the closest picture I could find that actually looks like the heart we draw on a Valentine's Day card, because it doesn't really actually look anything like that. But you get the sense that a person's heart's about the size of both fists if you put your hands together as such. That is the average size of the human heart about. And there are many aspects to the heart. This is an MRI image, moving magnetic resonance imaging scan. It kind of shows the basic function of the heart, which is to pump blood. And you see here the heart has 4 chambers, 2 larger ones shown here and 2 smaller ones on the top. Now the blood gets pumped through a variety of tubes, blood vessels. Shown in red are the arteries, which carry blood away from the heart. into the body, and there's over 60,000 miles of arteries in the body. So kind of being familiar with a lot of these is part of what we do in cardiovascular medicine. Probably some of the most important arteries in the body, aside from those in your brain, are those on the heart, and these are called the coronary arteries, so named because they resemble the crown in the way that they encircle the heart. And these red tubes are about the diameter of a telephone cord. They're pretty small, but they're vitally important because they bring blood to the heart muscle and keep it alive and pumping. Now, one of the things that that often makes the news, Bill Clinton had surgery, had a stent, cholesterol blockages. Everybody in this room probably knows somebody who's had bypass surgery or had some intervention, including a stent. But what we're talking about here is cholesterol narrowing of these arteries. And if that occurs, the heart muscle doesn't get enough blood. So when we exercise or do things, we can have chest discomfort or shortness of breath. A sort of extreme form of that is a complete blockage, which can occur very suddenly, and that's what we call a heart attack. A heart attack's when the heart muscle itself stops receiving blood and actually dies. And the heart muscle can't regenerate like your skin or hair. It doesn't. Once you lose heart muscle, it's gone forever, and that's an area of investigation. You may see on billboards. We're looking at stem cells to try to regenerate. But in general, once you lose heart muscle, you can't grow it back. So that's why we're always so kind of very direct at instructing patients to immediately seek attention if they think they're having a heart attack. Call 911. Now, bypass surgery is one way to treat blockages, and that's shown in this picture. And it basically involves, opening the chest. I don't have any actual pictures of that, but I think you can imagine you're opening the chest, you're many times stopping the heart, and you're sewing arteries or veins from the aorta, which is this big red tube, down to the arteries beyond the blockages. So you're essentially bypassing the blockages with a new plumbing system, and that's why it's called bypass grafting. Now, this procedure remains very, it's one of the most, studied operations in the history of medicine. Many of these operations are performed and are very reliable and reproducible, but it is invasive. And it's probably most useful for people with many, many blockages. But there's a whole family of technologies that I'm going to show you that can be done basically through a small tube, or what we call a catheter, that's placed in an artery or a vein, and that can be in the sort of groin area, in what's called the femoral artery, or even from the arm or wrist as well, even less invasive. And so one of the newer technologies that we use to treat blockages now are stents. So stents, this is a picture of a stent, probably some of you are familiar with this, but a stent is essentially a small miniature scaffold made of some type of metal. Now, the earliest stents were made of stainless steel. Now they're made of a cobalt chromium alloy, and they're very thin. The average stent thickness is like 36 thousandths of an inch. So these are very, very thin-walled structures that prop the artery open. Okay, so these are useful, I think, for people who have 1, 2, 3 sort of narrowings, but I mean, if you have 4, 5, 6, probably surgery still remains the option. But as these improve and become eventually bioabsorbable, eventually these stents will be made of a type of polymer that essentially is reabsorbed and disappears over a year. That's a trial we're involved in now at UC Davis that will sort of supplant the need for a permanent implant. Now, how did we get to this point? I mean, this is kind of an interesting story related to innovation, and I mean, the first heart catheterization, this was performed by this gentleman, Werner Forssmann. And he was a surgery resident in Germany, and he was frustrated with the lack of diagnostic information in the way that patients were treated. And he wanted to seek a way to try to gain more understanding of some of the pressures in the heart and the body that might influence treatment. So he made friends with the nurse, and because he knew it was against the rules for him to do this on himself. And I guess there might have been some romantic issue there, because apparently she volunteered to have it done on herself instead of him. But at the last minute, he tied her down. This is the story. He tied her down and did it on himself. He put a catheter in his arm. He just cut his arm, put a little tube, and then he took it, ran upstairs, and took an X-ray of himself. And this was the first catheter in the heart procedure ever performed in 1929, and he was promptly fired. Interestingly, he went on to win the Nobel Prize for this later on. So, more recent advent was the imaging of the coronary arteries with a catheter. And again, a small tube can be placed in an artery, and X-ray dye can be injected. Now, it was thought for many years that this was taboo, that you would essentially kill somebody if you injected X-ray dye or some non-blood material into these sensitive coronary arteries. And the story goes that Mason Sones, in this somewhat ghoulish image, was performing an angiogram of the aorta, and the catheter accidentally slipped into one of the coronary arteries during an injection. And you see here the artery is being, this is an actual image from that study in 1958, where the artery is being illuminated. And he dropped everything and he screamed out, "My God, we've killed the patient," and proceeded to be, in hysterics. But it turned out the patient lived, and aside from the heart stopping for a few seconds and then restarting, the patient did fine. And this was born really through accident, the use of coronary angiography. And we do this routinely now, today as part of the care of cardiac patients. And then really in the 70s, this is kind of the father of modern interventional cardiology. Andreas Grunzig in Switzerland postulated that you could put a small balloon into an artery, and you could use that balloon to stretch the artery open at a site of narrowing. And this very first angioplasty ever performed was on this gentleman, Adolf Bachmann, whom I just saw last year present at a cardiology meeting. He remains alive to this day. And they used a small balloon to treat a narrowing in his artery. And it was effective and remains open to this day. So some brave souls here that sort of paved the way for a lot of our current therapies. So some of the moving beyond the arteries, I think that technology in terms of stents, we've been using stents now for almost 20 years. Those technologies are fairly mature and I think fairly widely available. If you go to any cardiologist anywhere in the world, they're going to have stents. They're going to be able to talk to you about the risks and benefits of that therapy. I think broadening the scope of minimally invasive therapies, one of the exciting new areas is valve therapy. And the heart has 4 valves, and every valve has the same function. It's a one-way valve. A valve's supposed to open to let blood get through, and then it's supposed to close tightly so blood can't go backwards. So it has 2 functions. It has to open properly, it has to close properly. And shown here are the four valves in the heart. And you can have a variety of problems with the valves specific to aging. So the most common valve disease as we age is something called aortic stenosis. Aortic stenosis. And this is a thickening and calcification of the aortic valve. So on the upper right here you see a valve which is very calcified and doesn't open properly. And you can see there's just a very tiny opening. This should open like a large triangle, as we'll see. Some people are born with 2 leaflets instead of 3 leaflets, as shown in the right lower corner. But on the left side you see the consequences of a narrowed valve. Here in the center is, in fact, the narrowed valve, okay? And this main pumping chamber of the heart, the left ventricle, has to pump blood out to the body, and it's going through a tiny, tiny hole. So normally this should be about the size of a nickel, but in patients with aortic stenosis, it's like the tip of a pencil lead. So this is why patients feel short of breath, they have chest pain, they can't function when this valve narrows. Okay, and we know that this is a fatal disease. This is kind of like, incurable cancer. If nothing is done, we know that the median survival after this is either 2, 3, or 5 years, depending upon whether, your symptoms are at the time of diagnosis. And if you have chest pain, your average survival's, 5 years, but if you have heart failure, your average survival is 2 years. So once patients have symptoms with this, and having said that, you can live for many, many years, as shown by this line at the top. You can live for many, many years with aortic stenosis with no detrimental effect until you have symptoms. When you have symptoms, that's kind of sets the clock ticking for a bad outcome. So in properly selected patients with symptoms, the standard therapy has been a valve replacement. And this again is a highly invasive operation where you're opening the chest, you're opening the aorta, you're essentially cutting out the diseased valve and implanting an artificial valve. Now there are 2 basic types of artificial valves available. On the top is what we call a bioprosthetic valve. This is a valve that's hand sewn and manufactured of some type of animal material. In this case, cow heart, but they're also pig heart valves. And the limitation of this is because it's biologic, it degenerates over time, so the average time that this valve will last is maybe only 10 years before it degenerates and itself has to be replaced, necessitating another operation. The other type of valve is a mechanical valve. This is very durable. These are made of some kind of titanium, and they last a long time. But the downside of these types of valves is that you must take powerful blood thinners, which puts you at a yearly risk of some bleeding problems. So these can last up to 30, 40 years. But you incur a risk of bleeding. And the other issue is that, if you look at this yellow ellipse, this is all of the elderly, with severe aortic stenosis. And this is a disease of the elderly, and as such, there's more comorbidities, there's more other medical problems present that make patients high risk for a big operation. So of all the patients that might benefit, only a smaller percentage of that, this blue ellipse, actually get referred to open heart surgery. So many patients may simply live with this. So here is a technology that was FDA approved in 2011. November of 2011, and this was actually invented here in the United States. Despite the fact that we did the original investigations here, that it was invented here, that it's been shown to help patients, we were the 43rd country in the world to have this device approved, which says something about our medical device approval process, which is highly conservative and has a good and a bad side, right? I mean, we want devices to be safe and not hurt people, but there's also significant delay as compared to the rest of the developed world. But this type of valve is similar to a surgical valve, except that it can be implanted through a small tube or catheter. And you see the leaflets are the exact same kind of leaflets that are found on a surgical valve. The only difference is it's mounted on this metallic frame. And this valve can be crimped onto a balloon using a crimping device, okay? And this kind of shows an animation of the procedure. So the catheter is introduced through an artery in the groin. Here is the valve that's narrowed. So this kind of gives you a visual of aortic stenosis, and you can really see the issue there. Okay, so a catheter can be placed through an artery in the groin area, called the femoral artery, and a small wire is advanced through the aorta across the valve. And this is all done, on a beating heart. There's no, open heart, no incisions necessary. Patient is asleep, under general anesthesia. We use a balloon to stretch the valve open initially to make room for the new valve. And then the new valve is advanced on a catheter, which is still fairly large in this generation. You know, it's about the size of your pinky. The newer valves are going to be about the size of a pencil. But there are many patients that can't receive this because they have narrowings in the arteries in their legs and won't allow this tube to be advanced. Once the valve is in position, it's inflated on a balloon. Okay, and as it expands, it basically gets traction on the old valve, which just gets pushed to the side. And there's plenty of room for it in the majority of patients, and the new valve starts to function. So this literally can take less than an hour. And, you know, okay, so this, you know, conceptually is a lot less invasive than open heart surgery and would seem to be a great option for high-risk patients. And this kind of just shows like what we actually see as physicians when we do the procedure. We use a kind of X-ray guidance where you can see the valve being advanced around the aorta. And you see over here on the right side, the valve gets positioned in the old valve. And then when we actually inflate the valve here, you'll see the balloon being inflated and the valve being expanded on the left side here. Okay. You see up here on the upper right, this is kind of what that valve looks like when it's working. So you've gone from a very narrowed valve to a valve that opens well. So this, as I mentioned, is placed. This is the currently FDA-approved valve in the United States, the Edwards Sapien valve. All three hospitals in Sacramento actually do this procedure now, Sutter, Mercy, and UC Davis. You go through the groin, you go up to the heart. We do a lot of assessment of the arteries in the leg and in the pelvis to make sure that they're large enough to accept. Now, in some patients who have narrowings that we can't go through the leg, we can actually do a minimally invasive operation where we make a small incision on the chest, and we avoid the aorta. We actually just go in through the tip of the heart. This is called transapical access, and we put the valve in the reverse direction, and then we just sew this up. So the picture makes it look very easy. This is, of course, more invasive because it actually involves exposing the heart. There's an incision there. It turns out the tip of the heart is somewhat delicate. So this is definitely a little more of an operation. Now there's this small journal that I've heard of called the New England Journal of Medicine. I think it's somewhere in Boston. But they published two landmark articles looking at this technology. So this technology was studied rigorously that then led to the FDA approval. And I just want to show you a little bit of this data because I think it's fascinating. It's fascinating on a lot of perspectives. It's fascinating from the standpoint that it works and that patients do better. But it's also fascinating in the type of patient that this technology really was studied in. And you can see here in this table, we have two columns. We have the patients who underwent the aortic valve implantation called TAVI, and then we have patients that were medically treated. And what I want to point out is that the average age, okay, in this study was 83 years old. Okay, I mean the oldest patient in California currently received this was 102, and we did a 92-year-old last week. So this is a disease of the elderly, and as such, you know, if patients are functional and have quality of life, they can be candidates for this procedure. But you know, these are patients with a lot of other medical problems. What we know about this procedure is that in properly selected patients, that this procedure can actually make patients live longer as opposed to doing nothing. So this is mortality here on the y-axis. So at 1 year, okay, 50% of people with severe aortic stenosis who can't have surgery, these are inoperable patients, these are very high-risk patients with a lot of medical problems. 50% will be dead at 1 year versus 30% with the valve. So that means the number needed to treat, or the number of valves, is 5, which in medicine we talk a lot about the number needed to treat. That's the number of patients that need to have a therapy to save one life. And this is exceedingly low. 5 is a very low number, despite all the ads you see on TV for this medicine, that medicine, et cetera. Many of those numbers needed to treat are, 100 or more patients have to receive a therapy to have a life saved. So this is a very effective therapy in properly selected patients. This has also been studied in patients who could have surgery but were at very high risk. And again, these are very elderly patients, around 84 years old. Okay, and this shows that compared to conventional surgery, it's non-inferior. Okay, it was a little better earlier on. There were less deaths with the blue line, which is aortic valve implantation, as you might imagine, because it's less invasive. But at a year and up to 2 years, there's no difference. So this is what we consider non-inferior. It's not any worse than surgery. It's not any better than surgery. But I mean, honestly, if you ask a patient, you have a choice between, having your chest open or this other procedure. I mean, most patients will choose the catheter procedure. Now, I'm not getting into all the subtleties. I mean, clearly this is a first-generation technology. There are limitations. We can have a debate about which patients might have surgery and which patients might have a valve. There are some risks to this procedure, as you might imagine, of bleeding. When we put the valve in, there's a risk that a little piece of calcium can break off and cause a stroke. But I think that the totality of evidence shows that this therapy is at least as good as, if not better than surgery for elderly patients with a lot of other medical problems. Okay, I want to show you a little video. This is a video that actually shows the procedure and process. This is how we do the procedure. So we do this in what's called a hybrid operating room. This room at UC Davis has full capability for our catheter procedures and also full open heart surgery, and there's a large team of physicians that do this procedure. The valve comes in a little box like this. This is a 26 millimeter valve, and we go through a complete checklist before, just like before we take off in an airplane. You go through every check. You make sure we have every piece of equipment, everything's checked. We have everything lined up, ready to go. Here's kind of the groin area. I apologize if these images are a little bit much for this early in the morning, but you basically have these small catheters in the groin. Now here's the tube, this big blue thing here, that's the tube through which the valve is implanted, okay? And you can see we're just working in the patient's groin area here. We're not opening the chest. Okay, this is the X-ray picture of that tube, the catheter through which the valve will be delivered being advanced. You can see it's quite large. It's about the size, again, this for frame of reference is about the size of your pinky. Okay, so there's a team of us here. We work with our cardiac surgeons who assist with the exposure of the artery in the groin. Here's an X-ray picture of the aorta, and the valve that's to be replaced is in this area. Okay, you can kind of see the tube that we implanted through the valve. Now the first step, as we mentioned, is to cross the valve with a little wire, okay, and we use a tiny slippery wire to get through this tiny opening. Meanwhile, the valve is being prepared on the back table. It's rinsed and mounted onto the balloon at the time of the procedure, just like a surgical valve. Surgical valves are kept in a preservative and they're rinsed before implantation. We crimp this valve onto a balloon, and we do it at the time of the procedure because the valve cannot be stored in the crimped position because it would damage the leaflets. So the valve is only crimped at the time of the procedure, and we know, before we go in, of course, what size valve we're going to use. Now, these are a variety of devices used here to sort of crimp the valve down, okay, and you can see the balloon being placed in the valve, okay? The valve is really hand, mounted onto this balloon. There are some markers there that tell us. And of course, we have to make sure the valve goes on in the right direction, since it is a one-way valve. That's the first question, they ask. Fortunately, there's no one I know or other physicians that have implanted it the wrong way, but I think somewhere in the world it has happened. Okay, but that's not necessarily like a deal breaker, because you could just implant another valve within that valve, okay? And then you basically, and there are reports of putting 2 or 3 valves within these, they're like stents. You can put one in, put another one in, another one in. So Okay, so that sounds terrible, but there is an exit strategy. So what we have here is, the balloon being inflated, and now we're advancing the valve into this, this tube, okay? And you can see here, it requires some force to get it up there. This is kind of like showing the behind the scenes, video. So, no, we show this to our patients who have the procedure, so they have an idea what's going on. Here's the valve that comes around the aorta. And you'll see it being positioned here. It's being advanced around, this is called the aortic arch, because it makes an arch shape. Once the valve's in position, we also have an ultrasound catheter here that we kind of look at with ultrasound. And once everything looks good, we have the valve in the right spot. We kind of hold our breath and we inflate the valve. Okay, so this is a one-shot deal. You have one shot to put it in, and you can imagine that the limitations of this technology, right, are that, say it's not quite right the first time, what do? You can't really take it out, so you could put a second one in. So there are a whole series of second-generation valves that are now being developed that allow the valve to be collapsed and retrieved from the body, removed. You can put a different one in. So although this is amazing technology, there are other innovations that will make this even safer and more accessible to patients. Okay, so that's kind of what's new in aortic valve therapy. Just as a quick change of gears, the original slide here said man on the top and woman on the bottom. But that's not politically correct. So I changed this to aortic valve and mitral valve. But there are other valves. Now the aortic valve is actually pretty straightforward kind of problem because it just doesn't open properly. There are other valves in the heart which are more complicated. And I want to talk a little bit about what's called the mitral valve. So this may be timely given the news from the Vatican, but the mitral valve is actually named after the mitre. Okay, this Italian anatomist named the mitral valve after the mitre, which is the hat of the cardinals, not only in the Catholic Church, but in other Christian denominations as well. Not to be confused with the mitre saw, which is shown below, all right? But the mitral valve has two leaflets, as kind of shown here, and I guess if you have some good Chianti and you're living in 1543, you could imagine it looks a little bit like a mitre, a Pope's hat. But here it is, okay, and it sort of sits here, and it has a lot of, unlike the aortic valve, which is a simple thing that opens and closes, this has a lot going on. There are these sort of what are called chordae tendineae, or like parachute cords that suspend the valve, and these are anchored to these pylons called the papillary muscles, and there's kind of a ring around the valve. There's a whole lot of things that need to work here. So in select patients who have problems with this valve, there are solutions, and the problem is basically that when the heart contracts, the blood should go forward here on the left out the aortic valve and not go backwards. Okay, so this is the aortic valve we were talking about before. The blood should not go backwards. When you have mitral regurgitation, the valve, and this is the most common problem with the mitral valve in the developed world, is that the valve leaks. So blood goes backwards instead of forwards. And that's never a good thing. So that can cause shortness of breath, can cause enlargement of the heart, and heart failure. So in some patients, we will recommend open heart surgery to fix this. And the surgeons are a little bit like, an Italian tailor. They can go in and, trim this and hem that, and they can remove parts of the leaflet. They can sew it back together. They can put a ring around the valve. They have all kinds of procedures that can fix or repair a valve. So this is called a valve repair. This is where you leave the operating room with the same valve that you came in with. It's just that it was repaired, as opposed to a replacement, which you saw with the aortic valve, where you actually just remove it and implant a new valve. Turns out you can't actually repair the aortic valve, so the only way to fix aortic stenosis is to replace it. But in many times you can repair the mitral valve. So the kind of newer technology, and this is just one of many, but this also has been approved in Europe since 2008, still not approved in the US. It is investigational. We are the only site in Sacramento area doing this procedure, but this is called the MitraClip procedure, and I'll show you a little video here again of what this involves. So here you see the leaking valve, this blue geyser going backwards. Okay, and this is kind of the, this is the device. It is also implanted on the catheter. And at the tip is just this little mini kind of clothespin. Okay, this is also delivered through the groin, also, through the vein. And we can place a small tube inside the heart. Again, we do not have to open the patient's chest. The patient's under general anesthesia. It's on a beating heart. There are no incisions involved here. And this is done under X-ray and ultrasound guidance. But the clip is basically advanced here into the chamber above the mitral valve. This is called the left atrium. And then we use this valve basically to kind of clip the valve in the center. And I'll just kind of go ahead a little bit, but you'll see here the leaking and the valve. Okay, the little clip comes in under the valve, and we sort of clip it together in the center. So you would think, oh, this might be a problem. We might shut the valve off, but I'll show you why that's not the case. About 50% of the time, we will actually implant two clips side by side. And you see what it does is it generates what's called a double orifice valve. Okay, so instead of one large valve that leaks, okay, so normally the valve should be like a big smiley face. Instead of one big valve that leaks, we pinch it in the middle and we make two smaller valves here. This is called a bow tie procedure, and each of these smaller valves does not leak, but still opens sufficient to let blood go through. So this is called the bow tie procedure. It was actually invented by surgeons. They put surgical sutures in here, but this was adapted to a clip. And the idea is then you leave the clip in, and then at the end of the procedure, you can see the clip in position, and then you have much less regurgitation. So this is a kind of repair. We're not actually replacing the valve. But again, for the aging population in which open heart surgery is not a great option, this is a godsend for many patients. This is a kind of close-up of this clip. It's got over 30 individual moving parts covered with this Dacron mesh. The leaflets are grasped between these arms and these little gripper elements, and then it's tightened. And this thing is about the size of a dime. Okay, so they're different, the way, just kind of show you the way the procedure's done on X-ray. Again, we have a kind of catheter. Here is the clip being positioned. We can grasp the leaflets. We can put a second clip in if needed. And just as a visual, of the type of patients that we treat with this, these are not young, healthy patients, with no prior heart surgery. This is a patient who's had prior bypass surgery. Okay, they've had prior pacemaker placement, they've had prior angioplasty and stenting, and the heart function is very poor. And essentially, any surgeon who sees this patient will immediately run for the door and say, no, I don't want to operate on you, sir. So this patient received these two clips and had dramatic improvement. So this is really a useful procedure. And we are participating because this is still not FDA approved. Our FDA, being conservative as it is, still doesn't feel that the weight of evidence supports approval. And so we are still continuing our investigation in this in a multi-center national trial called COAPT, where patients are being randomized either to the clip or to standard therapy with medication, and we'll see the results of that in the coming year. So hopefully we'll have some approval. The final thing to talk about today, if I can just have a few more minutes of your time, is these are an exciting new group of procedures for patients with atrial fibrillation. And 1 out of every 10 people, kind of by the time they're in their 70s, will have atrial fibrillation. So I'm sure there's some people here who know what this is. but it's an electrical disturbance. And here you have on the top, you have the left atrium, and here on the left, you have the left ventricle. So normally the heart is like a two-chamber pump, like this top chamber contracts and the lower chamber contracts like a clock. So it goes tick, tock, tick, tock. In atrial fibrillation, okay, there's an electrical disturbance where the top chamber just starts to vibrate very rapidly, just kind of like jello. That's called atrial fibrillation. And because the top chamber is vibrating, the blood tends to kind of pool in areas, and the blood doesn't move through rapidly. So kind of like on the edge of a stream where you have your eddies and areas of slow flow, the blood slows up and it can form blood clots. And those blood clots could break off and cause a stroke. Okay, so atrial fibrillation, as I mentioned, this is the prevalence or incidence that increases with age. Here, if you look at the blue bars, okay, this is the total number of patients in the United States with atrial fibrillation, and you can see that it really peaks here, you know, in the 70s and 80s. Even though the total population declines, right, with advancing age, the incidence of atrial fibrillation goes up. So this is a significantly age-related phenomenon and will only continue to increase over time in prevalence because of other risk factors due to our wonderful affluent lifestyle, including hypertension and other issues that will lead to increased incidence of atrial fibrillation. So this is what we fear most with atrial fibrillation, is what we call stroke. So some little blood clot would break off. This is a brain scan, CAT scan, and shows an area of injury to the brain. This is called a stroke. And this is the EKG of someone in atrial fibrillation on the left side. So it turns out that over 95% of the clots that form in atrial fibrillation actually form in this little vestigial pouch called the left atrial appendage. And here's some pictures of it. And it was originally described as the left atrial auricle, meaning ear, in the first anatomic description, because it kind of looked like a little ear, but it's a little pouch. And it just is a reservoir for a clot. I mean, it's just in patients with atrial fibrillation, this is where the clot forms. You can see here on the lower right, clot forms in this area. And here is an actual echo image. This is an ultrasound image of a patient who, with atrial fibrillation, who has, like, you know, a clot. You can see this little circular material in the appendage. This is the reason why patients with atrial fibrillation are placed on blood thinners. Okay, so we have a variety of blood thinners that we give to patients with atrial fibrillation that could be as simple as giving the patient aspirin. But if there are other risk factors that we look at in a patient, such as heart failure, hypertension, age, diabetes, or prior stroke, we give a score, and if the score is above 2, then we give more powerful blood thinners to prevent stroke, such as Coumadin or warfarin, or a variety of other medications which some of you may be familiar with, called Pradaxa or dabigatran, rivaroxaban and Xarelto, or Pixaban, which is Equilus, I think. This was just FDA approved. So these are all wonderful medications at preventing stroke, but the flip side is, because they are anticoagulants, there is some small risk of bleeding every year. So you're basically trading a risk of stroke for a small risk of bleeding. Now, it turns out the risk of bleeding is far less than the risk of stroke in selected patients. So the risk-benefit ratio still favors giving a blood thinner, but this is something we keep in mind. And when patients have a bleeding problem, for instance, they might have a bleeding ulcer in their stomach or some other problem, then we have to stop these agents, and then they're at some risk for stroke. So again, keying off from surgical procedures that were done previously, surgeons have been sort of tying this appendage off and just eliminating it. They can cut it off, but this is done at the time of open heart surgery and is an invasive procedure. And there are just a variety of percutaneous devices now, or transcatheter devices, to occlude the appendage from the inside. And these are 3 devices we're working on at UC Davis now. But the idea is the same theme. You have minimally invasive. This is done through a tiny tube. Here's the appendage here on the right side. And the idea is to exclude this so that even if clot forms here, it cannot become free and go to the brain. So very carefully, of course, we advance a small catheter in here, and of course you can't have a clot in here at the time of this procedure, so we would only do this in patients who don't have a clot. But this is basically like a champagne cork. It essentially occludes the origin of the appendage. And this comes in many different sizes. It's of a self-expanding metal called nickel titanium. And then it's covered with the fabric, and then over time this essentially just heals up and becomes part of the heart, and you've eliminated the stroke. So potential, and this has actually been shown in a landmark paper published in The Lancet, premier British medical journal, which showed basically that if you looked at the risk of an adverse event, okay, with Coumadin, which is the green line, versus the device, that the device actually had less events over time than just taking Coumadin. This was the first trial. Again, this trial was published in 2009, so most of these procedures were done in the mid-2000s. This was the first time this procedure had been done in the world. And there was some small risk to the implantation of the procedure. And with refinements in the procedure, because there was 1 out of 100 patients actually had a stroke as related to the procedure itself. Okay, this was the early experience, but with the refinements, that was essentially, I think I got like 2 slides. Okay, just a little video here of some other types of devices that can be used, and I think just to close with this one, this is called the lariat procedure, and this is really interesting, another way that we can get rid of the appendage in patients. So it involves 2 catheters, and this is really kind of like a Western, Western-inspired procedure with a lasso. There's a small magnet that's placed in the appendage here. There's a small balloon placed here for positioning of the lasso. We actually enter the small sac around the heart and with a second magnet, and they link together, and this forms a little bit of a rail, we call. And then there's a little lasso that gets advanced, and again, this is just done through 2 small catheters, 1 in the groin, 1 right under the sternum. There's no open heart surgery here, and the lasso is placed around the appendage. All right, and you basically just kind of cinch it down. Once that's in position, you can remove the appendage, the magnet from the appendage, and complete the cinching procedure, and you've essentially excluded the appendage. So now, what happens to this over time? It basically just shrivels and goes away. Okay, and the only thing that's left behind is a small suture made of silk. And then that's cut and left behind. Okay, so this is another promising therapy that we're performing at UC Davis. So in conclusion, we have a lot of therapies. These are the wave of the future. We're involved in a lot of these. I'd be happy to talk. I'm on a website. You can look me up. I got my emails there if you have questions. I'd be happy to take any questions now as well, but thank you so much for your attention.
Dr. Rogers, that was absolutely incredible. So we'll start with questions. I'm going to try to go geographically. So any questions in the far, my left? There's one in the middle, and sort of 2/3 back. Wait for the microphone, please.
I don't need it. So if you look at standard cholesterol, I'm glad I get this the lipid panel, right? Bad cholesterol, good cholesterol, triglycerides, IDL, VLDL. There's a lot of other stuff on the internet now that seems like it's more specific. VAP, I think, is one of them. There's these other techniques. But if you read on those, they don't always jive with each other. So I guess my question to you is, Are those techniques, which may cost more money for the patient, are they there yet, or is it a false hope right now?
Yeah. So the question is regarding cholesterol, which is an exceedingly complex topic. But because there's just not one type of cholesterol, there are probably dozens of forms of cholesterol of different sizes and weights and et cetera. So the question is that there are many different types of cholesterol that we can measure aside from the standard panel that you get from your doctor. And are these other types of cholesterol measurements in fact helpful? And I think the answer to that is maybe. And I would appreciate your vote. No, just kidding. Yeah, I mean, I think this is a common theme in medicine. There's just a whole lot of things we can measure. And the question is, does measuring those things, has that been shown to, number one, identify patients at risk, and number two, do we have a therapy that we can give those patients that will actually affect their outcome? And so that's the big issue. There's a whole lot of things we can measure, but it's not really been shown that by adjusting a certain medication or giving a new medication and by altering those things that we can make the patients live longer, that we can prevent heart attacks, et cetera. So I think those are ancillary tests we may use. Those aren't the core therapies. And until we have good, large trials that show that those things actually make a difference, they're probably still kind of ancillary.
Hi. This was very interesting. Having had one aortic valve replaced because mine was bicuspid, why wouldn't you do this procedure on people who have to have it replaced again? I mean, obviously it's less invasive, so why wouldn't you do that procedure on the second valve replacement?
Yeah, so the question is kind of, can we do this on someone who's had a prior surgical valve replacement? The answer is yes, and we have done that. I just didn't show the images here, but it can only be done on people who have the biologic valve, okay, because the valve has to go in and it can sit in and displace if you have a mechanical valve, you can't put a catheter valve in because the metal won't, right? So you have to have that removed. So yes, that is a huge potential application of this technology, and we're doing it, and it's being done, globally.
I noticed, obviously, that none of these procedures involve putting the patient on bypass. Is that not necessary ever again for anybody, or are there certain procedures where you still have to put the patient on bypass?
Yeah, bypass, so the question is, do these procedures require bypass, and what is the role of bypass? Well, first of all, bypass is the heart-lung machine, okay, for those of you who might not be familiar. So bypass basically involves, you open a patient. Yeah. Bypass involves opening the patient, right? And then to operate on the heart, of course, the heart must be stopped and drained of all blood. Okay, so when the surgeon operates on the heart, they open your chest, they actually hook you up to a machine, okay, that has a pump and an oxygenator. So it's called the heart-lung machine. That is the bypass machine you're speaking of. And that drains all the blood out of the heart and lungs and goes to this machine and circulates while the surgeon operates. So that's called the pump time. That's called the pump. So usually the surgeons will achieve their operation within 1 to 2 hours while on the pump and then reconnect. So that is part of the major tax or morbidity of open heart surgery is that pump. Okay, and so yeah, the goal of all these new procedures is to not have any bypass support. We don't see that as a part of the future therapies.
One more question in the center. Let's see if I can come up and. No, we got it.
My question is, a lot of people that were in the 50s had congenital heart defects that seem to be occurring, is what I've read, that they're now finding that these people that had a hole in their heart are being repaired. Is that something that's now a process that's being done through the femoral artery as well? And what's the success on that?
Yeah. So the question is that there are patients who are born with abnormalities in the heart structure and function. That's called congenital heart disease. And what are we doing about those patients that survive to adulthood? And more of those patients are surviving to adulthood due to improved surgery early in life. although, you know, in many cases mortality remains very high, and many of those unfortunate children don't survive to adulthood. But yeah, absolutely, and there's a whole bunch of other procedures for closing holes, you know, opening holes that I didn't show you here. But yeah, I mean, I think the first line for any patient who's already had multiple open heart surgeries is to try to avoid another operation. So yes, there are therapies for those patients. I guess the flip side is that if we think about this in terms of a policy and a development perspective, you know, realistically what drives a lot of these technologies, right, is money, right? So what is the population, you know, how many patients in the country have this problem? Is it worth for a company to invest and develop a device? I mean, you know, this is the sad truth. So unfortunately, a lot of patients with congenital heart disease, these are very low frequency events. So although there's a clinical need in these unfortunate individuals, it's, you know, many of the solutions will not be developed because there's no funding for that, and there's nothing to pay for that. So,
fairly standard treatment then to do that, or if you did have a...
If we can in fact use these in that patient, yes. So yes.
Thank you.
Okay.
Thank you very much, Dr. Rogers.